paradigm has gained attention. And the main difference between the two is that they include international hospitals, whereas U.S. News and World Report is a strictly local review. There are a couple of other differences. One is that they separate neurology and neurosurgery. We don't have as much detail on their metrics, but over the past couple of years, Mount Sinai has clearly been doing well in U.S. News and World's as well, and Newsweek's even better. And so I wanted to share with you the recent results. Number 8, and this is the review. So the two international hospitals that are in the top 10, Queen Square and Charité in Berlin, and then Salpêtrière. And here you can see Columbia and Cornell, which are combined through a sleight of hand. Mayo Clinic, MGH, and Hopkins are ahead. So nationally, we are 5th or 6th. In New York, 2, and internationally, number 8. I think this is really due to the relationships that we have built, that you have built with international colleagues. And that's really why our name is out there, as well as things like our fellowship that has international graduates who know about us. So I think these are really important things. They feed great people wanting to be here, which feeds the quality of the program. So I wanted to share that with you. I'll also point out that in terms of NIH funding, we are number 24, but we're also number 1 in New York State for neurosurgery by Blue Ridge. And we anticipate that this should continue to grow. Looking at our peer institutions within, our peer departments within Mount Sinai, what you can do is look at U.S. News and World Report, and you see that there is some correlation that the top performing programs, cardiology and cardiac surgery, in U.S. News and World Report are also the top performing in Newsweek. And likewise, neurosurgery and neurology were 10, and we're roughly 10 now. Neurology is 11, neurosurgery 8. And so this reflects some parity over here. So the main difference between the U.S. News and World Report and Newsweek is the international component. And here you can see our New York peers as well. So I thought that was really, really great. And I wanted to share that wonderful news with you. Sonia is not here today. So we're going to repeat this next week. But many of you know that Sonia Nelson is retiring on November 4th. Look at when she joined. And that for sure is before most of you in the residency were born. She's been here 40 years. She will have been here 40 years. We'll recognize her next week, but I wanted to announce that Ruth Levy is on our side organizing donations. And I would like to ask that you consider a donation of $20 or more through Ruth Levy's Venmo account, which I will provide later. And this is towards a gift for Ms. Nelson. The hospital and nursing departments have also agreed to do something very special for her, but she really has been a stalwart, and I hope that you will consider a personal contribution of $20 or more. And we'll do a little bit more next week. Now we're going to turn to I actually have to stop the share and then restart it. Can you see Dr. Herrera's smiling face?
Yes, we can.
Okay. Well, it is a really great pleasure to introduce this year's Jeanette Bernard Post Memorial Lecture of Dr. Joseph Herrera. But before we get into a little bit about Dr. Herrera, I wanted to thank the committee. Isabel sent an email early on in this process with this recommendation, and it could not be more appropriate given the fact that Dr. Post's father was a rehab doctor. One thing that I wanted to mention is that Cal is at a meeting today. I don't know if he's joining us remotely. He knows this, the scheduling was unavoidable. So he's not here today, but he wanted us to go ahead with this lecture. So I wanted to thank the committee. There are several visiting professor committees, and the post committee is made up here. And I like what you guys have done and that you continue to include me. I appreciate, but that's really, really nice of you to do this and to handle this and to organize it. So Cal, who, as you know, is the professor and chair emeritus, established this lecture initially in memoriam to his father and then adding his mother later. They're both very unusual people, both way ahead of their time. His mother was one of the first litigators on Long Island and in New York. And his father was, as I understand it, because never met him, a very innovative, rehabilitation-oriented physician. And Cal established this along with several other beautiful things in this department for which we are forever grateful. This is the 20th year. So Cal's vision started 22 years ago and then established it 20 years ago. And if you look at who has come, you are in really great company, Joe. Chris Ragnarsson, who was the chair, was the first post-lecturer. Isn't that interesting? And here we are 20 years later with you as the lecturer. And you can see a group of really some of the most illustrious people in our field, not least of which are members of our own department, with Jay Mako and Tom Oxley, Eric Nessler, Chandra Sen. So it really is, you're really in some pretty important company here. And to the group, Dr. Herrera, I consider a personal friend. Although we don't spend a lot of time socializing, I think that we both feel very positively about each other as friends and colleagues. He is now the Lucy Moses Professor and System Chair of the Department of Rehab and Human Performance, which is the somewhat recent name of the department. He has become very interested in human performance. He's interested in concussion and sports-related injuries. He has recruited stellar people to promote this vision of an expanded view of rehabilitation. And he's also a hands-on doctor who performs procedures every week. He has many national roles, one of which that you see here is that he's the editor of the current reviews in musculoskeletal medicine. So Joe, it's a real pleasure to have you with us, and we look forward to your lecture and to continuing our collaboration with you and your department. And I'll stop my share with that.
Well, thank you for that. Let me just share my screen. Why is that coming up? Okay. And there. Okay. So first, thank you, Dr. Pedersen, for inviting me to speak here today to the committee. It is definitely an honor to be a post-lecturer. And it was interesting to see that Dr. Ragnarsson was the first post-lecturer. So this is truly an honor. And congratulations to the neurosurgery team for being ranked so highly in Newsweek and US News and World Report and having such accolades in Blue Ridge. Now, when I became chair in 2016, one of my missions was to bring innovation to the department. Interestingly enough, the past year and a half has seen a rapid adoption of innovation that we don't usually see in medicine. Everything from telehealth to even rapid adoption of new vaccines that a lot of people are resistant to taking, but still, a lot of rapid adoption. So today I want to discuss some of the updates we've made to our concussion program and how we've incorporated innovation in this whole process. Now, I don't have any financial disclosures here. I wish I did, but I don't. But as Dr. Pedersen mentioned, I am the official medical provider for Red Bull North America and for USA Fencing. And as a plug for our department, when I became chair, I rebranded our department from Rehabilitation Medicine to the Department of Rehabilitation and Human Performance. I always believed as a rehabilitation doctor that we were always in the business of improving and maximizing human performance, whether it's after spinal cord injury, brain injury, musculoskeletal injuries. And now we've delved into those who are healthy, meaning that we maximize both cognitive and physical health for our athletes, executives, and our average everyday Joe. Thus, our relationships with the Brooklyn Nets, New York Liberty, and the New Jersey Devils. So I also want to acknowledge Dr. Petrino and Kristen Dams-O'Connor for providing and sharing some of their slides for me today for this presentation. Okay, so before I started my career in medicine, I was an athlete. I competed both in high school and college. I was an NCAA athlete. I was also a coach before I entered medicine. I always pictured my career as one that dealt with biomechanics due to my understanding of mechanics through throwing, jumping, running, rowing. There was one night, though, when my focus turned from physical to cognitive. It was on March 12th, 2002. In Cipriani's, yes, it was a restaurant where there was an ESPN event. And this was my first day on the New York State Athletic Commission. And so let's roll the tape.
Oh man, chopping shot. And I think this one's gonna get stopped by Steve Smoger, yes. Stancil is out cold on the canvas. Little movement. Johnson picked his spot for the right hand, a right hand that Stancil did not see. The more experienced Johnson took Stancil into the deep waters, as we were talking about, and was able to really catch him. A nice clean shot late. Now those New York doctors were in that 11, ring. 224 KO. The fight was even officially stopped. Gold and Johnson, close fight.
So that was Chantal Stancil against Golden Johnson. It was the 11th round. And that night, my interest in concussion was born. Trying to understand and how to prevent CTE, how to prevent all the neurodegenerative processes that came along with head injury. Also, how do we manage concussion? So how do we care for those such as football players, lacrosse, soccer, boxers, from preventing further concussion and further neurodegenerative processes. So I became very much involved in trying to create our concussion program here at Sinai, along with our sports program. So today we'll evaluate our past concussion program, look at lessons learned, discuss some of the programmatic barriers and challenges, evaluate how we've now incorporated technology in concussion management, and discuss next steps. So to create a common understanding, concussion has, and its definition has gone through a number of different definitions, although minute changes here and there. This is the latest definition for sports-related concussion from the International Conference of Concussion in Sports that was held in Berlin in 2016. Basically, what it says is that sports-related concussion is defined as the immediate and transient symptoms following a mild traumatic brain injury occasioned during sports. Sports-related concussions is caused by direct force delivered to the head or anywhere else in the body, which results in an impulsive force being transmitted to the brain. In some cases, signs and symptoms evolve over a number of minutes to hours, and in most cases resolve spontaneously by 7 to 10 days. Providing the individual is not exposed to any further impacts, concussion is a common injury in contact sports with an incidence rate of approximately 1 per 1,000 athletic exposures in the NFL and up to 4 concussions per 1,000 player match hours in elite rugby union. So this became my focus. Now, these are CDC statistics. About 170 million adults participate in physical and recreational activities. 38 million children and adolescents participate in organized sports, and approximately 1.6 to 3.8 million sports and recreational related concussions occur per year. So in 2013, I partnered with Wayne Gordon and Joshua Cantor to start our concussion program through the department. This was in response to the Zachary-Lystead law, which was passed in 2019 in Washington State, which stated that athletes suspected of a concussion must be taken out of play, and only a licensed healthcare provider trained in concussion management can clear the athlete back to play. This law, this became law in New York State through the Concussion Management and Awareness Act in 2012, thus our 2013 launch of the program. You may recognize some of these people that are on this slide. So this was our Play Safe program that we developed. We collaborated with emergency medicine, neurology, neuropsychology, neurosurgery. You can see Dr. Chowdhury there, orthopedic surgery, pediatrics, and our own doctors here in the department. Some of these doctors have retired or moved on to other careers, but this was the beginning. Now, excuse me. When our athletes came to us, hopefully, they were some of our athletes that we did our pre-participation exams on, baselined them, whether they were high school or college athletes. Most often, they came straight to our office from the emergency room, or we saw them on the sideline. So that's when we started to see some of these post-injury evaluations. And then they would go on to our recovery protocol, which I'll highlight, reevaluate, and hopefully return them to play. Now, this is the SCAT. This is the most widely used, most commonly used concussion assessment tool in sports, which incorporates cognitive assessment, symptom reporting, physical examination, coordination, and balance testing. This is what we use to screen and what we use on the sideline, and even in the office as well. And most of you are familiar with this. This is the common graded exertion protocol. That's a return to play protocol, commonly used in the NFL. And as you can see here, initially, when we first started the program, step one, the initial recommendation was complete and total rest. Now that is no longer the case. Actually, complete and total rest, both physically and cognitively, may be detrimental to those who have been concussed. So we now recommend physical and cognitive activity as tolerated. And so what does that mean? And we'll get to how we help our athletes with that. Now, while most of our athletes manage to get through in about 7 to 10 days, okay, it's our athletes that get stuck in this recovery phase here. They get reevaluated, have continuing post-concussive symptoms, and continue to go on. Interestingly enough, some of our athletes that we took care of would sometimes miss semesters, so they sometimes missed a whole year of schooling just because of their post-concussive symptoms. This became an issue. This is an interesting article which stated that non-hospitalized patients with mild TBI have been recently described as the forgotten minority. And in 6 months after injury, 36% showed incomplete recovery as measured by the Glasgow Outcome Scale Extended. Only roughly 25% of non-hospitalized patients with mild TBI that originally presented to the emergency department for their injury seek an outpatient consult with a neurologist within 6 months of their injury. So this is a problem, especially those who have post-concussive symptoms. There's a delay in diagnosis, there's a delay in looking for treatment. So how do we fix this? So with the current program that we had that started in 2013, I started to reevaluate what our program meant, where the barriers and challenges were, and how could we make this program a lot better. So first off, there was an access issue. Some of the patients that were sent to us would not be scheduled until about a week to 2 weeks later, which was way too long. By that time, their symptoms had resolved. The second issue was data. We were doing all of this screening, especially with the SCAT, but the data was scattered. It was all over the place, and I don't think we were collecting enough data. The biggest barrier and challenge to treating those that were concussed is that there was a lack of objective measures. And this actually is where I started to really focus in. When I joined Sinai in 2005 and partnered with Wayne Gordon at the time, I started asking, what do we need to look for to say objectively that somebody was concussed? What we usually rely on symptomatic reports, symptom reporting, or impact, which again is very subjective, but there was no true objective measure. In fact, I got a study through the IRB that tried to look at CSF and blood products from our professional boxers immediately after they were done boxing. Mind you, none of them signed up for that, for a spinal tap. Okay. And a lot of the agents were like, yeah, nope, my boxer is not going to be an experiment. So we had 0 enrollees into that program. Although my passion for finding that objective measure still stands today, and I have some exciting things to share here. Also, resources. Some of our concussed patients came to us and started sharing some of the things that they wanted to know about, nutraceuticals, hyperbaric chambers, etc. So what did we do? So when I started looking at PlaySafe 2.0, I decided to combine that clinical program that we developed, look at what our athletes are doing, our P360 model. So Performance 360 is a program we developed back in 2017 that took all of the expertise in the sports world, everything from mental strengthening coaches, strength and conditioning coaches, to looking at technologies that helped improve performance both cognitively and physically. And marrying that with our Abilities Research Center, which is our center that is our house for innovation. It's an accelerator and incubator for newer technologies that help those in rehabilitation. So combining all these three things then caused us to focus in and look at a few different domains. So what are the key domains that we need to look at in order to make our concussion program a lot better? So you can see here around the different domains, we have cognitive, vestibular, cervical MSK, neuropsych, sleep health, audiology, and the autonomic, okay? The next slide is a little bit busy. And then we further broke it down into protocols. And you can see how each of these different buckets have different spaces in baseline protocol, post-injury protocol, and recovery protocol. All right. So mind you, we did not eliminate the medical piece of this. This is in addition to that. all right, which now makes our concussion program a lot more robust, okay? So we'll break this down individually. So as far as our new model is concerned, we were fortunate enough to field test this. We recently had a very generous donation to create the Charles Lazarus Children's Ability Center. Charles Lazarus was a founder of Toys R Us, and through that, we are now using technologies to help children. And we are now partnered with Fieldston. We have a concussion partnership with them and started screening all of their students. And we were able to pilot our baseline protocol. So our baseline protocol involved first the cognitive part using SCAT, brain check, and the BISC. I'll describe each of those as we move forward. Looking at the autonomic, meaning resting heart rate variability through a app called HappyTech. Looking at cervical range of motion through video computer vision. Looking at sleep health through the Pittsburgh Sleep Scale, Athletes Help Sleep Screening Questionnaire, and the vestibular portion, which is the postural sway app. Okay. So here's the SCAT. That's again standard. We did that for everybody. Now this is our fellow Chris Hoglid. He is using an iPad, okay, to quantify cervical range of motion. So there's an app that we're using that is using video computer vision to do the kinematic measurements immediately, okay? We then use this product called HappyTech. HappyTech is a, excuse me, measures heart rate variability by using the light on the back of an iPhone. Okay, it's validated. It's been shown to help those who are interested in heart rate variability, such as our athletes. And more importantly, what we were seeing for our concussed patients, from 2013 till now, was this exercise intolerance, and they would complain that their heart would race. And what we do know, and it's very well documented, that concussion can cause an overactivation of the sympathetic nervous system. So we are now baselining our athletes for heart rate variability using HappyTech. Now, this is a homegrown app. It's called the Sway app. More expensive platforms to check sway include platforms, force plate platforms, but this one uses an iPhone, okay, developed in our Abilities Research Center. Our athletes usually do a few different poses. First, double-legged stance with eyes open and closed. Single-legged stance, right and left, eyes open and closed. Tandem stance, left leg in front. Tandem stance again, right leg in front, eyes open and closed. And again, we use this app just to get the baseline. And after concussion, we will do that again after the concussed patient returns. Now, the interesting thing here is that this whole process of gathering all of this data took a total of 11 minutes per athlete, okay? We've now road tested this and have tested this on more than 350 kids over the last 4 weeks now. So between Fieldston and other schools that we're working with, we've gathered data on 350 children using this. So it's effective, it's quick, and it's scalable. So using technologies to use this as a baseline is doable. Now, a little bit about impact and going back to the cognitive base here. So impact is the most widely used computer-based testing module to baseline our NCAA athletes and also the professional teams. It has 6 modules: word discrimination, design, memory, X's and O's, symbol matching, color matching, and 3 letters. Now, the issue, though, is this is a study that was done here at Sinai. Impact has holes. Okay, so this was a study that looked at some local athletes here, NCAA Division I athletes that were screened. And what we found with impact was that there was an underreporting of concussions. Okay, so on impact, they asked, have you ever been concussed, and what is that number? And you can see here on the left-hand side, this has already been published, that 73 athletes, okay, reported 0 concussions. Now the BISC, which was developed here, the Brain Injury Screening Questionnaire, which has been validated, okay, shows that there was a discrepancy between impact and the number of reporting. So on the BISC, we asked the number of blows to the head, okay, and you can see here it ranged from 2 to 3. So, and interestingly enough, one of the athletes, who was a volleyball player, again, she was an NCAA Division I athlete, was one of these athletes that was in the group of 73. She had severe post-concussive symptoms and actually was reported, after we discussed it with her, that she fell off a horse twice and had a history of 2 big blows to the head, but reported 0 concussions. She actually was the one that missed 2 semesters of college just because of her symptoms. So, is impact good enough? I mean, it's what's there and what's most widely used, but we've now added the BISC to our screening process as well. Oh, okay. So this I'm really excited about. Excuse me. So this is NeuroCheck. This is a portable system capable of measuring steady state visually evoked potentials that was developed to provide an objective, quantifiable method of EEG testing following a traumatic event. So what this is, you'll see here in the front, is this is like a VR screen, okay, that delivers a 15 hertz flicker stimulus while this wireless EEG headset recorded occipital activity. Now, so this was used on 65 healthy rugby players, okay? And the players were instructed to stare at the screen fixation point while remaining seated and quiet. Mind you, they could keep their eyes open and closed. And what we were looking for was a signal, okay? And this was recently published in 2020. So this signal was found consistently. So there were a few different points when the athletes were tested. Pre-season, 72 hours after each match, okay, in order to validate this signal, all right? We'll come back to this a little bit later. So looking for this signal in normal individuals was important. Okay, let's now move to our post-injury protocol. So now we have our athlete. They now get concussed. What do? So we want to evaluate them within 48 hours, all right? We implement brain checks, the SCAT-5 again, neuropsych evaluation, I'll get to that in a second, brain gauge, okay? Again, check our heart rate variability, use the Buffalo Concussion Treadmill Protocol, we'll talk about that in a sec, and then look at our cervical range of motion. Some of these patients can have continued headaches, some of them are cervicogenic headaches, and then go through our sleep health and vestibular protocol, which now we add Frenzel goggles. Okay, so again, I'm super excited about NeuroCheck because here, okay, so out of those 65 athletes, there were 12 athletes that became concussed, all right? So this was the baseline, all right? And what you see within 72 hours of evaluation, that 15 hertz peak is gone, okay? It's gone. We didn't ask them about their symptoms. It just disappeared. All right. We then retested them after the clinician said that they were clear to return to play. And when they were retested, that 15 hertz signal was present again. Okay, mind you, this is a pilot study, all right? So this really excites me. It's an easy set of goggles that you can see here, all right, that you can use on the sideline, all right, to test and hopefully find an objective finding as far as concussion is concerned. So this I'm really excited about. I know that there are others out there, such as the eye tracking the eye tracking goggles. I'll talk a little bit about that when we get to the Frenzel goggles. But this really excites me. Again, mind you, this is only one piece of the puzzle as far as concussion is concerned. But again, very exciting. I think that there's something here, and we just recently got funded for some additional dollars to continue to investigate this. Okay, so Frenzel goggles. We have the Interacoustic Visual Eyes 505 Video Frenzel. What we're doing here is once a patient is concussed, we look for any nystagmus or saccades or anything that's out of the ordinary. Ideally, we would like to do this baseline, but I think it's a little bit overkill. So we're using it more for post-injury management. Now, the interesting thing here too is that we've also developed a program that does utilize some eye tracking because eye tracking is correlated with concussion symptoms, and there's detected convergence and accommodative abnormalities associated with concussion. So we believe that this is another objective measure. Okay, I know that Jam Jagar and a lot of the devices he's created, we actually have one of his devices here in the department, and Jun Maruda is continuing to investigate eye tracking. But just taking the Ambien, and this is from our professional athletes, have been able to trick that eye tracking, so they would take that for baseline. So it's a little bit flawed. So I think for every time we try to detect something, there's a way to get around it in order to get back on the field. All right, we are also utilizing Brain Check and Brain Gauge. Brain Check is a screening tool for anybody who has any cognitive concerns. It's used for people who have any memory complaints. It provides us with a quick and accurate way to assess cognitive function. It has standardized and customizable cognitive assessment batteries, and it can be done remotely. So interestingly enough, Brain Check we've been using not only for our patients who've been concussed, but a number of our COVID long haulers who still complain of brain fog. And we've been using Brain Check because they can do it at home. You can do it on an iPad or a laptop. And we've been fortunate enough to see how our post-COVID patients have been improving by using Brain Check. Brain Gauge, similar to Brain Check, is also a computerized model here that uses touch-based sensory testing to measure your brain health. It's quick and most accurate way to track movement, improvement in mental fitness. So it uses 8 essential components of brain health: speed, focus, fatigue, accuracy, and sequencing, and timing perception. So we love these computer-based models. Next, the other addition to our concussion program is now we have some of our therapists and physicians implementing the Buffalo Treadmill Protocol. Okay, so the Buffalo Concussion Treadmill Test is a validated test to measure the amount of aerobic exercise that is safe to perform, even in the acute phase for concussion. So the heart rate achieved at symptom exacerbation is called the heart rate threshold. So we usually tell our patients to exercise under that heart rate threshold. Usually it's about 70% of that heart rate threshold. So, and we use this in our next phase, which is our recovery protocol. All right, so our recovery protocol, you can see here, again, our different buckets. We use Neuron Up, again, a new innovative way of of doing some neurorehabilitation, neuropsychology. We then use the Buffalo treadmill protocol for our return to activity, and manual therapy for any cervical issues. As far as sleep, we've also involved some technology here, Sinai Health, I'll touch base on that, and vestibular and nutrition, I'll touch base on those as well. Okay, so the Buffalo treadmill protocol actually helps us get through these 6 phases of exercise through the exercise exertion protocol. Mind you, the Buffalo treadmill protocol is used primarily in stage 1 and 2 for our athlete to have post-concussive syndrome. And then we progress them through 3 through 6 once they get past that. But overall, it's been useful whether they have a smartwatch or a Fitbit where they can measure their heart rate. It's been useful in helping us help them get back to activity and get back to play. All right, a little plug for our Brain Injury Research Center. This is what our clinical and research program is integrated. It's for those who seek clinical services, and it also offers an opportunity for those to participate in research that continues to improve the care for those that have brain injury. So our department, I'm proud to say, is one of only 9 hospitals to be at both a brain injury and spinal cord injury model systems. We're the only one in New York State. Currently, our Blue Ridge ranking for NIH dollars, Kristen Dams-O'Connor is ranked number 6th in the country. Our department is ranked number 11 in the country. So we're really proud of that. So we use a lot of evidence-based processes here for neuropsychology. So if any of your patients need that, please let us know. So research indicates that TBI education that includes clear and empirically based information to set recovery expectations is associated with shortened recovery and better outcomes. Now more than ever, since TBI is increasingly viewed as a risk factor for neurodegenerative diseases, there is an understandable iatrogenesis that can perpetuate cycles of symptoms. So our TBI education includes promoting a recovery-based mentality, provide education about concussion, set a positive expectation of recovery, and prevent iatrogenic effects. We have this whole educational program that looks at Concussion 101, what to expect after sustaining concussion, coping with symptoms, exercise and activity pacing, and progression, vocational recovery, and return to work. Now, excuse me. As far as the neuropsych evaluation, usually it's the common referrals come about as cognitive, whether they have attention issues, memory, executive functioning, emotional, behavioral concerns, return to work, school, and activity.
Did we just lose his connection? Let me text Joe.
I see him still on here, but muted with screen off.
Muted and screen is frozen though, right?
Yep.
I think the connection is gone.
Yeah. I'm going to text him. And I'm going to call him as well.
So sorry about that. It just lost power here. Oh, geez. Okay, here we go. Let me see if I can get us to the right place here. Okay. Let me just get us to the right place. And we'll continue. Sorry about that. Okay, here we go. All right, this is where we were. The purpose for this, the neuropsychological evaluation, is to inform diagnosis, define strengths and weaknesses, suggest best treatment options, track recovery over time. And the process here is use of pen, paper and pencil and computerized testing to measure cognitive abilities. This is usually an in-person evaluation. So for our more severe patients, we refer them to the Brain Injury Research Center. Now, as far as short-term cognitive rehabilitation, supportive psychotherapy, and empirically supported interventions such as sleep, fatigue, pain management, anxiety, and mood are incorporated in the evaluation here. Interestingly enough, we provide guided relearning of cognitive skills and developing strategies to compensate for loss or weakened cognitive function. So overall, this program is robust and complete, and not only do we help those with concussion, but post-stroke, post-brain injury, post-surgery, anything that causes any cognitive issues, the Brain Injury Research Center is the place to go. Now, NeuronUp, excuse me, is another platform that we're using. Now, this is different from the Brain Injury Research Center in that it's a web-based platform. It's designed to act as a key support for occupational therapists and other professionals involved in cognitive rehabilitation and stimulation processes. It consists of a number of materials and resources for designing treatment sessions, in addition to patient manager for organizing and saving the results of those sessions. So NeuronUp is a web-based program that can be done anywhere. So for our patients who are homebound or are afraid to come to the hospital, we've now transitioned to NeuronUp as a way to give them cognitive rehabilitation. The great piece about NeuronUp, though, is that it's customizable. You do have a dashboard that you can see whether or not a patient is doing well in certain domains and adjust what they need to be doing moving forward. So we're really happy with NeuronUp as far as another option for neurorehabilitation. Sana, okay, so Sana Health, back in 2017, we held the hackathon here at Mount Sinai. And Sana Health actually won the hackathon here for their innovative product that we see here that helps those with pain, sleep, and anxiety, sleep disturbance and anxiety, by using these goggles, okay, that have both auditory and visual stimulus, okay, and also checks heart rate variability. And what we see here is that by wearing these goggles and using this for any of the sleep disturbance issues that our patients have, especially with those that have post-concussion syndrome, has been absolutely useful. And another tool, again, one of the tools that we're using, some of the innovation that we're using to help those that are concussed. All right, so as far as our concussion network is, concussion recovery network is concerned, as I mentioned, access has been an issue. You know, now we have we've established a pipeline from the emergency department, and we guarantee that a patient will be seen within 48 to 72 hours of injury, okay, of referral. We've created this concussion care hotline, concussion@mountsinai.org. So if there's anybody that needs any help, that's manned 24/7, and just send us an email and we'll get them in right away. And already from the schools that we're covering, we've had a number of concussions coming in daily. All right, so let's talk about next steps. So as far as our play safety plan, we are continuing to expand out to other schools. Dr. Cancel, who is our new recruit, he's our pediatric physiatrist, and also involved in the New York State Athletic Commission. We are in discussions now to create a combat sports clinic that focuses not only on concussion, but other issues related to that. And pre-pandemic, we were in the process of creating a remote concussion evaluation program for the Red Bull Academies that's located in Austria. That has restarted up again. This is for their hockey players as well as their soccer players and basketball players that play in Europe. So we're developing that program as we speak. As far as the TBI research is concerned, our rehabilitation neuropsychology faculty at the Berk is very much involved in the latest and greatest. Some of the current projects include the late effects of TBI, the brain donor program. This is the program where a number of the former NFL players have donated their brain to. Ultra high field imaging of post-TBI epilepsy, physiological mechanisms of executive attention recovery, bridging transitions from post-acute care, clinical trials, TBI and health in adults. We have a number of focus groups, everything from groups that help the patient and also those who are caring for the patient. And we have a randomized controlled trial on online emotional regulation training as well. And as I mentioned, we recently got funded for continued studies on neurocheck. Again, look out for this. I think that this may be our objective measure. Again, it's only one piece of the puzzle. I hope that we can find something more behind that. This is a whole topic and lecture on its own, but this I'm very excited about. And the other thing that we're doing is we're partnering with Thorne Nutraceuticals. Thorne is a very well recognized company that's provided nutraceuticals for the Olympics and a lot of the professional sports due to their process of making sure that there are no other ingredients that may alter an athlete's ability to compete in the vitamins and minerals and supplements that they provide. The product that we're looking at is benfotiamine, which has shown some benefit in Alzheimer's. We don't know its effect on concussion yet, but that's something else that's currently being funded as we speak. So hopefully you were able to gain an understanding of our current concussion program and how we are now using technologies to improve our concussion management. I still think that there are a lot of other next steps besides the ones that I've outlined, including hyperbaric chambers and looking for that elusive biomarker. I think we're getting close. So I want to send a special thank you to our team, Dr. Petrino, Kristen Dams-O'Connor, Jenna Tosto, our doctors, Miriam Zachary, Chang Cancel, Adam Fry, Amy Kim, our fellows, Jasmine Harunian, Michelle Leong, Chris Hoglet, Daniel Spunberg, and our therapists, Chris Lewis, Tracy Lynn, and Erica Brayman and Layla Nasser for making sure that our patients get cared for. And also, please follow us on Twitter and Instagram at Mount Sinai Rehab. We are at Mount Sinai Rehab. All right, any questions?
Dr. Herrera, that was really spectacular and very worthy of the 20th post-lecture. I'm sure that Chris Ragnarsson would be amazed and proud to see where your department has come. Are there any faculty or attendees who have comments or questions?
Yes, I would love to make a comment. This is Dr. Chowdhury. I'm sorry I don't have my camera on. I'm still stuck in traffic, but I enjoyed your lecture tremendously. And as you know, many of us in our neurosurgery department are interested in this topic. I appreciate the shout out for me, but you know, Zach Hickman and the whole New York Neurotrauma Consortium, which you guys are very much in the lead position for, and even Dr. Morgenstern and other pediatrics. I guess, you know, I think your approach overall has a lot that we can learn from in terms of looking at multiple technologies and applying them in smaller areas first, like fields in a school. I think there's so much we can learn from. I think I agree with your general principle that we need more objective tools, even though I do a lot of research with impact. Each one of these tools has some limitations, and I think there's a lot of areas of overlap. We're doing some work in collaboration with hyperbarics and others. And I guess my question for you is, first of all, congratulations on the presentation and the work. But my question for you is, COVID has brought up an interesting set of issues, both with the disease itself, as well as perhaps even the vaccine, in terms of inflammation and neuroinflammation, as you know, is an issue of importance in brain injury. And so I guess my question to you is, are you doing any specific research in this area? And if so, I would love to collaborate.
So yes, we are doing some research around COVID, looking at brain check. Actually, I'll be presenting to the CDC tomorrow, actually, at 2 p.m. So if anybody would like to tune in, I'll be presenting on the program that we've developed here that is now going national. That is the graded return to activity physical therapy program that Jenna Tosto and our therapists have been diligent about helping those with post-COVID or the long haul syndrome. You know, the initial numbers right now is that those who enter our program for both fatigue and brain fog, we are implementing a breathwork program first, right? That's through our partner, Stasis. They're a set of Navy SEALs that teach those how to do breath work. We implemented that for our post-COVID program, and then a specific return to activity program for our post-COVID patients. So I'll share some of the initial findings right now, but what we're seeing is that those who entered the program, as compared to those who have not entered the program, are recovering 40% faster, okay, when they are in our program. So we've been fortunate enough with working with a post-COVID clinic that we have a long wait list to get into our therapy programs and into our rehabilitation program in general. And so we have those metrics, and these patients are being given these surveys consistently, and we're seeing a plateau for those who don't make it into the program and those who are getting better. Yes, the answer is yes, we're looking at this. We're even looking at different diets, as you can imagine. The non-inflammatory diet through our nutritionist has been a hot topic. The low histamine diets as well. So I think COVID has been a source of a lot of research opportunities and a way to find help for patients. I mean, we're so early in the disease process as we speak right now. So, yes, the answer, if you're interested, we definitely can use more hands on deck. Because I know our staff and our researchers are very stretched between their own projects and now COVID on top of that. So,
yeah, thank you. And I
Thank
think
you very much. Let's move on from COVID. Joe, would you be kind enough to stop sharing your screen so that we can?
Joe, I have a question for you. First, thank you so much for sharing this breathtaking lecture and experience with us. This is really a masterpiece. We have a lot of residents today, and one of the topics that we reviewed recently was the concept that apps tend to be a little bit easier to introduce in our field. And you eloquently said that COVID actually showed that technology comes in faster, especially when we need it. So I would like if you could spend just a couple of minutes going from the idea of an app and to the implementation of it. You've shown it in your lecture, but I just wanted to get a few more hands on deck, like you said, so that the residents can have a better sense of how can that happen. Thank you.
thank you. Okay, thank you for the question. And the implementation or adoption of technology has been challenging for medicine in general, right? When you look at the ideas around health technology and the disconnect between what's made, what's funded, You have all of these venture capitalists that say, "Oh, this is the next great idea." They go to their the engineers, software engineers, to the other engineers, and sometimes a clinician who's somewhat involved but not really. So I think the best way and the best way to develop an app is in-house. Look at your own practices, see what the deficits are, see what the need is, and then work backwards. More often than not, there is this big, what they call the valley of death of technology. And from the first capital funding for apps, products, et cetera, and getting it over that valley of death so that it's clinically integrated, that's why I built the Abilities Research Center and recruited Dr. Petrino and all these other people in order to get over that valley of death, right? So I think the best source for apps and technology is going to come from us, right? It's the doctors, the physicians, those who are in the trenches who see the problems and say, this is the solution. Now, in the Abilities Research Center, we do have some brainstorming sessions. I know that Dr. Kellner is very much a part of that. We invite everybody here who has an issue to come and share with us what those issues are. And we can brainstorm and see what works, what doesn't work, right? Because not all technology is perfect. So, and that's why right now we're field testing this. One piece that I knew needed to be solid was the timing. That's why I pointed that out with the use of the apps. Because if it took forever to upload every single person into those apps, it would be no good, right? Especially when we're screening and we're doing all these athletes marching through, forget it. So that was one of the criteria we had as far as building the app. So what is the need? Work with an engineer, and make sure it's on multiple platforms, not just one. Okay, so that's a big mistake. It's only on the iPhone, or it's an Android app, right? And then do your pilot study, see if it's viable, and then move forward. The problem too today with medicine is that randomized controlled trials, unfortunately, take forever, right? So by the time you're done, 5 years, 10 years down the road, the app is obsolete. So clinical trials, I think, is the way to go, right? So doing rapid adoption maneuvers, getting it through the FDA. So we helped APOS Therapy do that here in the United States. I think the big message here is a successful app comes from within. Find the problem and move it forward.
Any other
I had a question
for residents? Please go ahead.
Hey, Dr. Herrera.
But what I wanted to ask you is, we talk a lot about return to play in kids, and it's a huge problem. But I think an even bigger problem is return to school, because that affects the entire spectrum, non-athletes as well. Have you guys worked at all on that or talked about protocols for return to that kind of activity?
Yes, yeah. So it's the return to learn activities, right? And so the return to learn protocol, it's similar to that guided exertion protocol that we have for athletics, very similar. And we follow that for cognitive stressors, which is school, screen time, et cetera. Now, one piece that has not yet been quantified is screen time, right? So when a patient sits, when you have a child or a patient that's constantly on their smartphone or in front of a computer, should you eliminate it completely? Not necessarily, right? So we use the same principles as the Buffalo treadmill protocol, try to find where their upper limit is, and that's something that we share with our parents. What's the upper limit of cognitive performance? Is it a half an hour? Is it pen and paper? Is it sitting in front of a computer? Okay. So we use those different metrics to help guide return to learn.
Alexander?
Hey, Dr. Herrera. I'm Alex. I'm one of the third-year residents here in our program. I also work in Dr. Chowdhury's lab and have done a lot of work on impact. And as a former college athlete as well, I can tell, there are obviously some limitations as someone who used to take impact all the time. You mentioned the subjectability, but But I think one of the merits of impact, as you know, is just the accessibility and the relative affordability of the test. And I think I've thought a lot about over the past couple of years of what is the best field side concussion test that we can really administer. And from what I've gathered, there are two real limitations, right? One is the cost and one is the resources needed. It'd be awesome if we could really do a great biomarker study looking at serum and CSF of all of our athletes. But as you know, and as you saw firsthand, it's not really so viable. So I'm curious, now that you guys have really delved into all these different technologies and these new startups, what have you gathered as far as what the best, maybe in terms of broad scale, what do you think the best direction is in terms of on-field testing and field-side return to play guidelines and how we can best administer this? Because obviously we can't offer this $10,000 eyepiece to Hodunk High School in a rural town, right? They're never going to be able to afford something like this. So what do we think is the best kind of method in terms of wide-scale accessibility to assessing concussion in our young athletes?
That's a great question. So, that's why one of the pieces, besides the NeuroCheck, that can be done sideline, all right? But that's a piece of equipment that we don't even know what the price point is yet for that, right? Hopefully it's going to be affordable. Interestingly enough, the initial study for that used Google Cardboard, okay, with an iPhone in it, with the transmission of that signal, that stimulus at 15 hertz, and then these EEG signals. So it's doable. And then they developed that whole nice VR set, right? So actually, Dr. Petrino and I always talk about like affordability and making sure that this is accessible. We're talking about maybe doing a Google Cardboard version of that, making that accessible for our Lazarus children, right? Now, the other piece here too, objective measures for concussion. That's why we're piloting the Sway app, looking at physical measures as well, okay? It's objective, could be subjective if the patient wants to continue to sway, but usually they want to get back out in the field as opposed to prolonging injury. Excuse me. But I think that there are a number of different avenues you can still go down. That eye tracking still is out there, all of that work, along with this signal that we're starting to see, as far as objective measures, So that app, we are going to make that free and available for schools in general. We have this whole concussion kit that we're going to be giving all the schools that sign up with our Lazarus Center that includes that. So I think we're going to find a way to find objective measures to measure concussion on the sideline. I hope, those are just, again, all small pieces that lead to the bigger picture.
Kurt?
Thank you so much.
Kurt, do you have any questions or comments? Chris Kellner? Kurt?
I guess I had a quick question, or something I was thinking about. There's a lot of correlation in my mind between concussion and proceeding through neurosurgical residency, and just your comments on doing a baseline testing at the beginning of residency and see how that kind of progresses throughout residency to see how things change neuropsychologically. I think it would be something I was interested in kind of thinking about the potential future research. And we've been working with, as you know, Dan Turner, Chris Kellner, Dr. Petrino on our own performance enhancement program. And I think that's part of that, but I think taking a step further and looking at the intern versus chief level to see how it changes over time, I think would be very interesting. So again, thank you for your talk and comments.
Yeah, no, I think that's super interesting. And that delves into our Performance 360 program, looking at how we can improve performance for our own doctors, right? How do we recover? How do we change? What is our makeup moving forward as you go from a first year as an intern all the way to a full-fledged attending, right? So that definitely interests me, and I know that we're actively working on that as we speak.
And I just want to say thank you so much for developing this system for assessing performance, because it really is applicable to a lot of different disease processes. For me, stroke; for Dr. Chowdhury, for spine recovery. And it really becomes a system that you can apply to really any member of our department could make use of it.
Thank you for that. And we're very proud of it.
Well, that was wonderful. Are there any other comments or questions? Joe, did I understand you say that you can reverse visual evoked potentials using Ativan? That the athletes trick the machine?
No, so with the goggles, not visual evoked potentials. This is the eye tracking.
Eye tracking.
Eye tracking. So we heard from one of our NFL athletes that one way they trick the goggles is by taking Ambien.
Ambien.
When they do the eye tracking, it's a little bit wobbly. And so if they do get concussed and do it again, there's no difference. I mean, I don't know if it's true. It's just hearsay, but it's what's out there for those athletes who.
You mean they take the Ambien to induce wobbliness, so
Exactly.
there's no delta from right after when they were hit.
That's right. That's correct.
Brilliant. Okay, you threw that in there. I wasn't sure I understood it. Are there any other comments or questions on this wonderful post-lecture?
Zach Hickman here. I just wanted to thank Dr. Herrera. That was an excellent talk. And, I think access to all this great technology is often, one of the issues we have, and the resources over at Elmhurst, obviously. And I think leveraging technology to kind of offload the need for some of the manpower sometimes it's going to be kind of key going forward too. So thank you.
Thank you. And I agree 100%.
There's a good question in the QA here from an attendee.
You know what, though? I think it's at 9:02. People who want to stay certainly should. I wanted to thank the selection committee and Dr. Herrera for this. And I'm sure Joe would be willing to stay for further question and answers.
Sure.
Thank you.
Thank you all.
And there was one question here that I think is relevant, especially it's, in the high level athletes organizations where performance is directly related to profit and revenue. Have you seen pushback in implementing the data you're finding? And if so, how have you attempted to manage these obstacles?
So that is true. So having dealt with a lot of the professional teams, the kings are the agents and the trainers and the coaches and the owners. Sometimes they make decisions that are not at the best interest of the athlete. We are fortunately or unfortunately, we are not yet there as far as implementing some of the technology that we're developing. We did get some interest, especially with NeuroCheck, with the NFL. Although I think it's still pretty early on, so we just are not there yet to see if they will adopt it or not. I know that with the goggles, the other goggles, the eye tracking goggles, I think the majority of the athletes ended up showing that they had some concussion. So it was not adopted wholly by the NFL. Some teams do implement it, but not all.
And then one other question here was, that there are some links now, as we see in the aging population, between concussion earlier in life and increases in dementia and other neurodegenerative disorders later in life. Do you know of any sort of long-term studies, either here at Sinai or elsewhere, that are looking into interventions that can help reverse the effects of concussions early in life?
So that's a tough question. I mean, trying to reverse concussion. So through our Brain Injury Research Center, there is that longitudinal study that's looking at late effects of TBI. I think that's the closest we're getting to that. But overall, I as far as other studies, not yet, but definitely interested.
We have other questions.
Other questions?
I see one hand up. I'm just trying to give him a chance to.
Hi, this is Mel Proskoff in New Hampshire. Excellent talk, Dr. Herrera. We've got all our little local high schools here in New Hampshire and in rural areas where obviously it's hard to get all the finances that you have in New York, but it's wonderful, and there's a lot that I can take back to the local organizations. Is there a linkage between Sinai Biodesign and your Abilities Research Center in terms of developing the new technologies, or is it basically software, or are you doing hardware stuff too?
So we're both, and there is a link. We do work with Sinai Biodesign. Dr. Petrino does. So yes, there is a link there, but we are a separate division within the department here. We work collaboratively with them, MSIP, et cetera. So it's both hardware and software that we look at. So we look at different technologies that vary in maturity, some that are conceptual, all the way to those that are very mature, to see if they will stand the test of clinical trials. So overall, we're really happy with what we see, and this is just one of the products that we've seen. I didn't even tell you about all the 10, 20 other products that were concussion related that we just did not go with at all. It just was A, too expensive, or B, too cumbersome to implement in the field.
Okay, that's very good. And having come along with having trained with neuropsychology going back 100 years, it's tremendous seeing the metrics applied to neuropsychology. So it's much more of a science than it previously had been.
Yes, no, and I have to give Kristen Damza-Connor and her group there a lot of credit, and that's the reason why she's currently ranked sixth in the country for applying metrics and looking at ways to really measure outcomes for our patients.
Thank you.
Thank you.
Thank you very much.
Thanks, everybody. Chris.